So I'm going to start with the topic matters close to my heart and hopefully yours, cardio-oncology in breast cancer. These are my disclosures. So my objectives today are to cause grade 2 tachycardia. Yeah? No. No, okay. Review the epidemiology of cardiotoxicity in breast cancer patients. That's what I want to do. And secondly, I want to talk about the new ASCO guideline recommendations for the prevention and monitoring of patients receiving cardiotoxic regimens. And so when I originally submitted for this, there was no ASCO guidelines. These were actually published in December of 2016, so they're only about 3 months. So I modified it to kind of highlight what those new recommendations are. So let's start off with our first polling question. Which of the following is true regarding cardiotoxicity of anthracycline-induced cardiotoxicity? I'll let you guys read them and choose the answers. I think I might have been gone happy on that one, so okay, good job. No, that's actually not right. But okay, well, we'll go on. So the epidemiology of breast cancer. So I think the epidemia of breast cancer has a bright side and a very dark side. So what's the bright side is that we have made major therapeutic progress in breast cancer. There is more breast cancer survivors now than ever before, and you can see the epidemiological numbers there, and that is absolutely fantastic. But the dark side to that is that there's these women, you know, the treatment of breast cancer hasn't changed in the past 15 to 20 years, right? The cornerstone of therapy has been and remains an anthracycline, you know, patients getting anthracycline treatment. And those patients who are getting, who are HER2 positive, the cornerstone of therapy and the standard of care is not only do they get an anthracycline, but they also get trastuzumab. So these are women that we're curing them of their disease, but are receiving these cardiotoxic agents. And so what we're seeing is, and this was a study that was a retrospective study of about 12,000 women, and they looked at the incidence of cardiac, heart failure, and cardiomyopathy. And you can see in women that just got anthracycline alone, their hazard ratio was 1.4. Trastuzumab alone, and this is surprising, was 4.1. That's kind of surprising, right? I kind of scratched my head at that, because when you think of trastuzumab and you think of an anthracycline, anthracycline seemed more cardiotoxic than trastuzumab. And then when you got the sequential anthracycline plus trastuzumab, your hazard ratio for developing heart failure or cardiomyopathy was 7.19. That's big. That's awful. And so when you look at these numbers, you're like, wow, those are high numbers. And you're like, oh, you know, Zini, this is retrospective data. Yeah, I agree it's retrospective data, but I believe this data. Why do I believe this data? It's because when you look at the incidences of cardiac toxicity in our breast cancer clinical trials, you know, we know this. These are younger women, not a lot of comorbidities, the cream of the crop patients. What I think these numbers represent is real world. The older patients, the patients with comorbidities, hypertension, smokers. These are patients at increased risk for negative cardiac outcomes. So I do believe these numbers. I think these are more real world numbers, and I think clinical trials historically have underestimated the cardiotoxicity effects of our treatments. When they looked at this longitudinally of when is this heart failure occurring, you could see here they looked at it over a 5-year span. And so in the first year, they're relatively low numbers, not startling. You know, for anthracycline, only about 1%, trastuzumab close to 4%, and the combination about 6%. Well, as you increase years after their completion of therapy, you could see that by year 5, the numbers are drastically much higher. So if you just got anthracycline, 4% of women had cardiac heart failure, trastuzumab, 12%. And in the combination, 20% at year 5. And you can see that this data is illustrated on this graph. So over time, you're seeing a cumulative incidence of cardiac heart failure in these women that receive these cardiotoxic therapies, which is, I think, extremely significant. Moving forward with this data is that what we're seeing is that women who are diagnosed with breast cancer are not dying of breast cancer. That is amazing. That's awesome. But what are they dying of? They're dying of heart disease, and that's what's illustrated on this slide. And what's interesting, you're like, oh, well, Sandy, everyone dies of heart disease. That's everyone's #1 cause of death. True, I agree. But in this patients that are diagnosed with breast cancer that are dying of heart disease, if you look at what I have written here, is that only 25% of these women had a cardiac history or comorbidity before starting their chemotherapy or their treatment. That means 75% of women died of cardiac heart disease that really didn't have any cardiac heart disease before their breast cancer therapy. So that brings us of where we're at today. So we're seeing all of these breast cancer survivors, and I think cardiologists are seeing these breast cancer survivors. I ran into my cardiology pharmacist. She's like, "What are you doing to your patients, Sandy?" I'm like, "Nothing. Why?" I'm like, "I'm curing them." She's like, "I'm treating a 42-year-old with heart failure." And I'm like, "Really? That's terrible." Because what has our relationship been with the cardiologist, right? So I was telling my resident, I said, our historic relationship with cardiologists was like a one-night stand, right? Hey, I'm going to start this patient on these drugs. Tell me what their heart failure, what their EF is. Give me that information, and I'm done. I'm done with it, right? And that's how we did. We got a baseline MUGA. Maybe we got a MUGA after they were done, and that was the extent of our relationship with the cardiologist, right? And so that wasn't working, right? That wasn't working. The cardiologist recognized that. The oncologist recognized that. And the cardiologist like, you know what? We want more. We want a relationship with your patient. We want to make this, more of a longitudinal, where we want to meet your patient beforehand. We want to do a risk factor assessment. We want to look at more preventative strategies. We want to be able to detect the cardiotoxicity. We want to be more involved in your patient. So that's where cardio-oncology has emerged as a subspecialty in cardiology. How many of you have cardio-oncology clinics at your practices? Raise your hand. Okay. All right, some. So this is a new, relatively, I would say the past 5 years, we're seeing more and more cardiologists that are specializing in their cancer patients. So these are the cardio-oncologists. And again, their goal is to treat the cancer but protect the heart. Okay, and this is coming in, and it's primarily, I would say, the push has primarily been breast cancer, but definitely our pediatric patients and our other patients, our leukemics that are getting anthracyclines. But I think that just by the sheer numbers, it's the breast cancer that really has pushed this to the surface. So looking at cardiac risk factors. So as I mentioned, ASCO it published their guidelines in JCO of December of 2016. And again, I've been working in oncology for 14 years, and I never really looked at, risk factors. I just thought, oh, well, their MUGA's good, we're going to treat them. Their MUGA's not so good, we're going to give them an anthracycline sparing regimen. But I didn't really look at patient risk factors such as smoking, hypertension, dyslipidemia, their age. We really didn't look at that. And now ASCO is saying, well, you know what? You need to look at these risk factors, because if they're getting cardiotoxic drugs and they have these additional risk factors, that patient is at increased risk for cardiac dysfunction. So that's important and new. The second thing that I like to draw your attention to, let's ignore the radiation, because radiation causes valvular disease, and I'm not really interested in that, and that's not really the purpose of the talk, but I listed it there to be complete. But let's look about this high-dose anthracycline. So what did we learn as pharmacy students, young pharmacy students? High-dose anthracycline, what dose resonates with you guys? What dose is that? Just say it out loud. 300. Do I hear a 500? It's about 400 to 500 milligrams per meter squared. This is what we learned, that at this level, this is the lifetime cumulative dose where we get concerned, where we start seeing increased negative cardiac outcomes, right? So when you go from 400, you have a 9% of patients are experiencing a ejection fraction decline. When you go up to 550, it's like 18%. Above 700, it's 48% of patients are having ejection fraction decline. That was our reference point, has been high dose. Well, in the new guidelines, they looked at that data and said, you know what? It's changed. The data has changed. And now looking at newer data, newer prospective data, they pulled the analysis and said, you know what? That threshold has changed. That we're actually seeing a 9% decline in ejection fraction when patients hit a cumulative lifetime dose of 250 milligrams per meter squared. Okay, and it exponentially gets larger when you go to 500 or 300 and 400. When you go to 400 milligrams per meter squared, I think it's more like 38%. So that's a big change, guys. This is a big change. What we're calling high-dose anthracycline is greater than or equal to 250 milligrams per meter squared. Okay, so that's high dose. So we're thinking in our breast cancer population, like, well, we're at 240, so we're still kind of okay there. And then the other treatment-related risk factor is low-dose anthracycline. So by this new definition, low dose is that less than 250 milligrams per meter squared plus trastuzumab. Now those patients are at increased risk for cardiac dysfunction. So what have been our historic, prevention strategies? Well, we've had primary prevention strategies and secondary prevention strategies. You can see that I didn't spend a lot of time on these primary prevention strategies. Why? It's because we're familiar with them and we kind of don't really use them, right? So continuous infusion. We know that the cardiotoxicity is associated with high peak levels. So if we give it by continuous infusion, you don't have those high peak levels and you have less cardiotoxicity. We know this, but guess what? We don't do it. Why don't we do it? Well, the clinical trial didn't do it that way, although there's no difference in efficacy. We don't suspect that there's different efficacy given a continuous infusion versus IV push. But it's a vesicant, and we don't want to give a vesicant continuous infusion, so this is not an attractive way to give doxorubicin, and I could tell you that we don't do it. Liposomal doxorubicin, that's a primary prevention strategy to get a less cardiotoxic anthracycline. Well, yeah, we could do it, but all of our data is with the non-liposomal, and it's not indicated, so it's not like we're going to switch it, and especially in patients that are curative intent. And then finally, dexaroxazine. This drug's been around for decades. Cardiologists love this drug, and they can't understand to the fullest degree why we don't like this drug. The data's there that it absolutely protects the heart when you use it. And I think it's debatable on whether or not it compromises efficacy. What they did see in some analysis that there was lower response rates, and I think that scared the bejesus out of us. We're like, oh, well, we're not going to do it lower response rates. We're not going to risk it. So we're not using dexaroxazine as a cardioprotectant in our patients, and it also has a narrow therapeutic labeling. I think it's metastatic patients who've gotten who you're going to exceed 300 milligrams per meter squared of anthracycline, then you can consider using it. So those primary prevention strategies haven't been really heavily utilized. Well, what's the newer primary prevention strategies that are being looked at? Well, heart failure drugs, right? So we know that the outcome is cardiac left ventricular dysfunction. So what if we incorporate an ARB or a beta blocker before they get these cardiac treatments? So that's what the PRADA study was. So the PRADA was looked at 120 patients, and they did an echocardiogram, they looked at biomarkers, and they started patients on either candesartan or placebo or a metoprolol, and they followed them over a series of time points. And so what the results were that if the patients got candesartan, they did see a less of a decline in their left ventricular ejection fraction versus the beta blockers. The beta blockers really didn't show a difference, but you could see that this wasn't statistically significant. Another study that looked at this was the MANTICORE study. Again, another small study, 99 patients, and this time it was in HER2/neu positive patients. And they decided to also do, cardiac assessments and then start these patients who, again, don't have any, they don't have hypertension, they don't have heart failure, so just starting them on an ACE inhibitor or a beta blocker, and again, starting that, a week prior to them receiving trastuzumab therapy, and then doing serial cardiac exams thereafter. And again, when you look at the results of this, the placebo, you saw the placebo, they did have reduction in baseline EF by about 5%. The ACE inhibitor only had about 3%, and the beta blocker about 1% decline in their baseline EFs. What they also found is that these drugs were well tolerated. They did protect, to some degree, the decline in LV dysfunction, but they didn't meet their primary endpoint, which was prevention of ventricular remodeling. So that brings us to where we're at with primary prevention. So I think one of the highlights that we're now looking at is looking at these modifiable risk factors and doing more of a risk factor assessment. That we're not all treating all our patients. Every patient that comes through that door is not being looked at the same. That you're taking that patient with those individual risk factors and you're going to look at them through a different lens. ASCO does continue to recommend dexamethasone, continuous infusion, and liposomal doxorubicin where you can. And their stance on the use of these heart failure meds is they don't really recommend it. They say that the data is too limited at this point, and it's not enough for them to recommend it out of the gate. But I'll tell you that this is an area, area that has a lot of data is emerging, and I expect a little bit more research results soon. And this is just an example of one of the studies. So looking at the more sexy part of what I think this presentation is secondary prevention. So again, I think secondary prevention is what we're all very comfortable with. What we are doing in our patients is we are monitoring left ventricular dysfunction at baseline and at regular intervals. And to some degree, we did it at baseline and then we did it at the end, but we didn't necessarily do it at regular intervals. And I think that has been changing to some degree. But in looking at that, Cardinale is an Italian who's probably one of the forefront researchers in this area. She conducted a study to evaluate the clinical relevance of anthracycline-induced cardiomyopathy in response to heart failure therapy. So this slide, I expect some tachycardia from this slide. Okay, here we go. Okay, so what she found, or what she studied, is that she looked at the time that they finished an anthracycline and had a heart failure, and the time between the heart failure was diagnosed and the time they started heart failure therapy. And so what they found that if you waited 1 to 2 months after completion of the anthracycline and you started heart failure meds, that the ejection fraction, that you had 64% of patients had a response. That means their ejection fraction improved after starting that heart failure medicine. If you started meds 1 to 2 months after. If you waited 2 to 4 months, then 28% of patients responded to their heart failure meds. Okay, this is the point that's important. Look what happens at the 6-point mark. I don't think I can use this. At the 6-point mark, if you waited to start heart failure meds 6 months after them, completing they had an ejection fraction decline and they finished their anthracycline. If you waited 6 months, then started heart failure medicines, it was essentially irreversible heart damage, right? So why does this cause tachycardia in me and should in you? Is that because what do we know about doxorubicin? We said it's a cumulative toxicity that's irreversible. What this data is suggesting is, well, if you start the meds earlier, that it actually potentially can be reversible. And that's exciting. I think that's exciting. I'm having a tachycardia right now as I'm saying it. And you can see here the responders and the cardiac-free event on this lower graph. So if you were responding to these heart failure meds, you were free of a cardiac event, unlike the non-responders and the partial responders. So this is exciting data. So that brings us to early detection strategies. So how can we early detect? Because I think how we've been operating and why the cardiology pharmacist gets upset with me, and not recently because we're much better at it now, it's because our mentality was that we're not concerned that our patients are getting cardiotoxicity because we were operating on the fact that, our breast cancer patients aren't getting that high cumulative dose. And we're not seeing them. But what happens is we're done seeing them and the cardiology sees them. And by the time the cardiology sees them, there's already a decline in their ejection fraction. The damage is done. So I think that we have to rethink about how we're doing it and looking at, well, is there a way to intervene before the damage is done? And so that's what these early detection strategies are looking at. So what are the diagnostic tools cardiologists have to detect ejection fraction decline? Well, we have 3. We have a MUGA, the multi-gated acquisition, the echo, and the cardiac MRI. So the classic here, the one that is the gold standard, is the cardiac MRI. Unfortunately, though, this is limited because it's not very accessible and it's extremely expensive. So we don't even have one at our academic university. The one that we're most familiar with is MUGA, right? That's like we need a baseline MUGA. I mean, I don't know how many times I've said that in my career as an oncology pharmacist, MUGA, 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 MUGA. And you guys laugh because you agree with me, right? And yeah, it's accessible. It does expose patients to radiation. But the limitation of the MUGA is that it gives limited information on cardiac structure and diastolic function. So there's a limitation there. Echo. We're familiar with echocardiogram. It's accessible. What the good thing about the echo is it provides more information on the structure of the heart and the diastolic and systolic function of the heart. So the echo is a little bit more informative, okay? The other bonus to the echo is that the echo can give us strain. Strain is a hot buzzword in cardiology. Like if you guys were cardiologists, you're like, oh yes, we love strain, strain's the best. But you as pharmacists are like, what's strain? Okay, so let me tell you what strain is. So when the heart contracts, right, that is strain. So it changes, the heart contracts, it changes the length of the heart. And any change in length of the heart is called deformation of the myocardium. So, you know, the heart contracts, it's changing, it's straining, it's changing the length of the myocardium is changing in length. And that change in length is called strain. And so what the echo can do is the echo can look at segments of the muscle, heart muscle, and look at the strain of the segments of the heart muscle around the heart. And so they can detect if the strain is abnormal, they can detect that. And see what happens in, say, like a MUGA report is that you can have parts of the heart muscle that are not functioning at 100%. But because of the contractility of the heart and the other muscles, those other stronger muscles mask the weaker muscles, if you will. And so what strain does, it allows us to dissect and be able to determine where the muscles are having more weakness, okay? And so you could do that regionally. And so why it's called global longitudinal strain is, well, first you could do strain longitudinally, circumferential, and radial. But the one for ejection fraction that we're interested in is the longitudinal strain. And global is because they're looking at each section of the heart and measuring the strain. And so what happens is that your ejection fraction will appear the same, right? And once the ejection fraction goes down, it's like the cardiac damage has occurred. What the strain is telling you is damage is occurring. And so you can intervene earlier. And so the strain has become the American Society of Echocardiography and the European Association Cardiovascular Imaging says that when you have a global longitudinal strain greater than 15% from baseline, that is likely abnormal. Now, I didn't include all the studies, but there's about 6 or 7 studies that look at the sensitivity and specificity of change in global longitudinal strain and its ability to predict a decrease in left ventricular dysfunction. So with the anthracyclines, if you get a greater than 10% change in your global longitudinal strain, then you are going to have your problems with the ejection fraction in the future. With trastuzumab, it's about 11%. So this is globally, this is changing the way we look at our cardiac exam. So we're going to start talking about this in terms of strain. And I think what's important here, and I have in the first bullet point, is we're trying to detect subclinical ejection fraction. That's what we want to do, is subclinical. So the idea is if we detect it early, we can have measures or intervene at an earlier point before the final damage is done. So this is what is being done. And I'm not going to spend a lot of time on this, but this is exactly how they do this global longitudinal strain, is they do it through speckle tracking. And so speckle tracking is these little dots that they see in the myocardium, and they follow those dots in each, they take a picture of each frame as the heart is contracting, and they're calculating the change in length or the strain in each of those frames. And so that's how they determine the global longitudinal strain as a cardiologist is measuring this. So ASCO's recommendation, because of this data, says like if our preferred diagnostic imaging for these patients is an echo with strain imaging. It's not to say that you have to do echo with strain imaging, but that is that preferred. You can also do a cardiac MRI, and a MUGA is still acceptable. But again, I told you that there's limitations to the MUGA in terms of it's not going to be able to tell you that subclinical harm that we're doing to the heart. Another area is biomarkers. So for ages, we've known that troponin is a protein that's exclusively in the myocardial cells, and we know it's a marker of cardiac injury. And so we have, data to suggest that when the troponin is elevated after giving patients cardiotoxic chemotherapy, that they're likely to develop some type of left ventricular dysfunction in the future. And so this was, again, from Dr. Cardinale illustrated this in this study where patients that received, it wasn't just breast cancer patients, it was also leukemics in this study, received cardiotoxic drugs, and then she measured a troponin early versus late. So when you look at the troponin levels and you see, minus, plus, minus, it's because the first is the troponin, whether it was positive or negative, early, which was, I think, within 72 hours, and then late was a month after. And so what you could see here is that the troponin predicted if these patients were going to have a negative cardiac outcome. So you could see here that if you had a negative troponin early and late, that you essentially were free of a cardiac event. But if you look at the extreme, the lower line where you had a positive troponin early as well as a positive troponin late, those patients did not do as well. They were more likely to develop a cardiac event. So again, you could see the predictive values that are listed there. So the recommendations for ASCO on secondary prevention is that patients that are at increased risk for cardiac toxicity in terms of their diagnostic workup and as well as their longitudinal following, that an echocardiogram is the preferred diagnostic with global longitudinal strain, and that considering troponin as a cardiac biomarker and obviously getting a cardiologist involved. So this is an example of a Mayo Clinic's Cardio-Oncology service. And you could see here, they published this before the ASCO guidelines were published. And so they describe their cardio-oncology service. So again, they do something quite similar as they look at medication risk factors as well as patient risk factors. And they do a risk stratification assessment. So based on their risk, incorporating the patient risk factors, smokers, hypertension, diabetes, females, and looking at their medication, they will classify their patients based on a point system if they're very high risk, intermediate risk. And you can see what the monitoring recommendations are. So if you're very high risk or high risk, and you go to Mayo and go to their cardio-oncology service, they're recommending an echo with strain for their very high risk and high risk. And what's changing between very high risk and risk is the intervals of how often they're getting that strain, much more frequently in very high risk versus high risk. And in addition, they're saying, well, you can optionally get troponin also, but really what their gold standard is echo with strain. When you look at their management recommendations, again, very high risk, what they're doing is they're initiating heart failure meds up front. You could see that in their very high risk patients as well as their high risk patients, they're starting them on an ACE inhibitor or a beta blocker, statins if they need to. So they're being much more aggressive that if they've identified you as very high risk or high risk, that you are going to start a week before starting chemotherapy. So again, this is where the relationship starts with the cardiologist. It starts a week before they start treatment, that they're going to start these heart failure meds and then start their chemotherapy. So what does our protocol for anthracycline monitoring look like? You can see it here. At our institution, we do a baseline echo with global longitudinal strain, and we consider troponin. The problem with troponin is that it's hard to get the patient to come back within 72 hours for a troponin level. I mean, it's just a transportational, logistical problem that we have. So we would like to, but it's not always something that we, make patients do. And again, this was designed pre-ASCO publication. So we defined a high dose as greater than 240 milligrams per meter squared. I suspect that we may change this with the new publication, but you could see what what we're considering high dose anthracycline is at 240 milligrams per meter squared, and again, getting that at completion of therapy in 6 months after. And again, let's look at the Europeans. The Europeans are always ahead of us. Look what this was published in 2012. Again, much more, they're always ahead of us. And you could see here that the Europeans were already recommending echo. They were already, for anthracyclines, recommending troponin. And if there were troponin positive, you could see that those patients were starting on an ACE inhibitor. So in summary, before the ticking bomb it goes off, is that breast cancer patients are at increased risk for cardiovascular disease, and hopefully that's that take-home message, is that we can no longer just monitor them with MUGAs. We have to be much more aggressive in their monitoring, because these women are experiencing these negative cardiac outcomes. Cardio-Oncology is a new emerged subspecialty that follows these patients, so it's no longer that one-night stand. It's this beautiful longitudinal relationship they have with the patient, with their being a little bit more actively involved. The changes that it's no longer, I feel like this isn't a change in decades, and now finally we're looking at a risk assessment, we're looking at different diagnostic imaging, now we can consider cardiac biomarkers, so there's all these newer secondary prevention strategies that we can implement and hopefully prevent these negative cardiac outcomes.